And the last bacterium we need to discuss is one of the most famous and the most interesting bacteria is the mycobacterium. Actually, we have several species. First of all, we will talk about mycobacterium causing tuberculosis, and classification again recently was reviewed and slightly changed. And nowadays, mycobacterium causing TB is combined together in one genus named as Mycobacterium tuberculosis complex. Previous decades, every bacteria was classified as a separate species, but now they are combined together because of one disease they can cause. Actually, we have several species, about 9 of them, but 4 of them are most important, most frequent. It is the Mycobacterium tuberculosis in situ, Mycobacterium bovis, Africanum, and Microgyne. So one thing which is always confusing for students, as you can see in the central picture in the slide, it is a lot of blue color, like a filament and some spots, and red rod-shaped bacteria. Actually, that rod is Mycobacterium tuberculosis, and it is red. But bacteria is identified and described as a gram-positive. That thing is confusing because actually that picture is not gram stain. Mycobacterium is known as an acid-fast bacteria, and always during classes when you're answering about some other microbes, you say that bacteria is non-acid fast. Actually, in your program, we have only one, and the only bacterium which is really acid fast. It is Mycobacterium. Acid fast means bacteria can resist activity of acids during some staining techniques, and that property is due to presence of high amount of different lipids and waxes in the structure of the cell wall of mycobacterium. And due to those unique components, bacteria can resist activity of concentrated acids. And when you will apply Zell-Nielsen's technique, usually it is essential in diagnosis of TB in clinical samples in sputum. And when you will apply that technique, everything else will be stained in blue color, but mycobacterium will be red. And as the result of Zell-Nielsen staining, mycobacterium appears as dark red. But it is not a gram stain, that's why bacteria is that color. If you will apply gram staining technique, usually it is possible when you're studying pure culture of bacterium. Bacteria will be gram positive, it is blue. But in gram stain, if you remember the technique, all solutions, all dyes used for identification of bacteria are based on water, they are aqueous solution. And of course, if you try to apply some aqueous solution on lipid bacteria, their aqueous solutions will be easily washed away. And microbe is very poorly stained. It is pale and almost invisible in slides. And if it is pure culture, you will identify that bacteria because you know that it is here and nothing else is present in the slide. But if you take clinical sample, always in that sputum you have number of different other microorganisms, normal flora bacteria, some epithelial cells, some macrophages, some dust particles, and a lot of stuff which will be stained very good by gram technique. And then that contrast in the background of blue, perfect blue color of other bacteria or red color of other bacteria, that weak and pale stained mycobacterium will be easily lost. That's why specific technique is used for identification of mycobacterium. Again, it is a Zell-Nielsen stain. So as you can see, bacteria in clinical samples is looking like a curved rod-shaped bacteria. It is obligate aerobic by type of respiration. It is non-motile, non-spore-forming, and non-capsulated. One of the unique property of mycobacterium, because that complex composition of the cell wall, bacteria cannot grow very fast. And actually, for regular bacteria, doubling time is about 30 to 40 minutes. Mycobacterium requires almost a day, about 18 hours for single multiplication. And of course, it's making growth of bacteria and cultivation of bacteria very difficult. Usually, some amount of microorganisms can be identified in culture medium in about a month or even more. And environment, bacteria is very resistant to drying. It's resistant to multiple antibiotics, usually used in routine practice. And again, unique technique is used because it is resistant to main number of dyes. They all are based on water. So few key points about tuberculosis itself. If you remember that first semester, we said about Robert Koch, and one of the goals of his activity, of his work, was identification of mycobacterium, and actually that microbe was discovered in 24th March 1882, and today the day is pronounced by WHO, World Health Organization, as a World Tuberculosis Awareness Day. And every year we kind of celebrate in that day by providing some information in network, in some other giving information to people what is TB, how to identify, how to look for help, where to go. And it is still very important day because one of the main ways to prevent disease and recognize it in timely manner is providing correct information to community. So almost 20 years ago, World Health Organization stated that because of tuberculosis, we will have about 36 million people died and about 150 million persons ill because of TB. So that year is very close to be finished, and we will soon know is it really so or not. But actually, it's looking like yes, TB is still very important and dangerous disease. It is in top 10 by reasons of death in general, and it is one of the most frequent reasons of infectious death worldwide. Really a lot of people is infected with TB. About 200,000 kids died because of that TB a few years ago, and that rate, of course, is very scary because even now, when a lot of antibiotics are available, good diagnostic tools are available, still the disease taking a lot of lives. According to official data, about 60% of all TB cases are registered in 6 countries, including India. And as you can see on that slide, Russia is not included, but I do believe that it's just underdiagnosis of the disease in our country, or maybe poor official data available, but rate of TB is extremely high in Russia as well in last years. And actually Russia should be here among those countries. Again, we have that group of risk of immunocompromised people such as HIV patients, and of course decreased immunity in them, leading to much higher mortality rate due to TB, and rate of infection with mycobacterium is much higher in HIV patients. And actually those diseases are very good attached one to each other and always goes in pair in HIV people. So one of the most important problems is the latent state of TB. It is kind of carriage, but it's not correct to say, but common idea is the same. We have people who are asymptomatic, they're not suffering from any problem, but they can spread mycobacterium to environmental objects and to people surrounding them. And mainly they are the source of infection. They can infect a lot of people, and actually disease is going for years, for even decades. And of course, a lot of people who are in close contacts can be infected by one person, and it's very difficult to identify and to give proper management for that subject. Cultivation is difficult as well because bacteria is extremely slow growing. It requires unique composition of culture medium. The classic culture medium is LJ medium or Lowenstein-Jensen medium. And nowadays we have some modifications which is known as VINN2. Any culture media looks like the same. It is greenish in color, and mycobacterium, if it will grow, will form granular colonies of yellow to brown color. The colonies are small and have that unique consistency you can see in the right picture on the slide. And we have a set of culture medium named as a Middlebrook. We have Middlebrook agar, we have Middlebrook broad. It can be slant, tube, or plate. And as you can see, colonies growing in that agar are transparent, small, granular in texture, but if we will talk about viral factors of mycobacterium, again, it have huge number of them. I will show you only the most important and the most famous. Major component of mycobacterial cell wall is a mycolic acid, and actually name of that acid was given because of unique appearance of mycobacterium in slides when high magnification of microscope is used. They're looking like a filaments. Sometimes it resembles fungi, like a mycelium of fungi. And actually, because of that fungi appearance, uh, disease was, the component was named as a mycolic acids. Mycos is a fungi. In clinical presentations in people, that component leading to formation of unique histological inclusion known as a so bacteria as well have phosphatides which are responsible for another type of tissue damage known as a caseosis necrosis or caseotic necrosis. And bacteria again is rich with different dense or hard lipids, waxes, which are combined with proteins, and actually they're responsible for unique immune response, delayed hypersensitivity, and in diagnosis they're responsible for tuberculin sensitivity. We will talk later. Another important factor is known as a code factor. It is unique chemical compound which responsible for formation of, so to say, serpentine codes. Bacteria are arranged in columns. Again, I will show you in the next slide that picture. And in immunology, the component is responsible for inhibition of chemotaxis of immune cells, and that core factor is the reason why disease acute and very chronic way with formation of unique granulomas. As well, bacteria have polysaccharides, uh, which are responsible for immediate type of hypersensitivity, but in clinical presentation and diagnosis, that type of reactions are is not used. So, few slides of unique appearance of mycobacterium. It is a kind of coding of mycobacterium, you can see that a lot of microbes are arranged together, forming some common figures, like a parallel lines or some jellyfish, some octopus or some other. A lot of descriptions, a lot of components. But as you can see, arrangement is very unique, and it is due to core factor and mycolic acid. So pathogenesis of the disease is very difficult, and actually, if you will take a look at some pictures or sorry, books or literature, you can see a lot of different descriptions because information. Actually, disease again is known from Koch times, and disease always described in some new manner when a new method of diagnosis became available, or new more better microscopes became available. More and more information became known about the disease, and it is very frequently changing. So we have again several classification of TB. We have clinical classification, we have anatomical classification, we have histological one. So we will describe and I will give you some only common types of classification combined. And in pathogenesis, we have actually two types of TB manifestation. Of course, it is infectious disease, and always some damage will be formed in tissue. We have two types of lesions or two types of inflammation. First one is an exudative, it is a acute type of inflammation when a lot of edema will be absorbed in those people, fluid will accumulate, a migration of immune cells after infection with the mycobacterium. And actually, that type of inflammation resembles regular bacterial pneumonia with corresponding symptoms. Usually, that type of proliferation or the type of inflammation will heal by resolution if subject is immunocompetent and no problems with immunity are observed, or in ill people with some immunological disorders or with poor prognosis. That type of inflammation can be reversed to massive necrotizing of tissues and poor outcome. In third case, exudative type of inflammation can be changed or switched with the productive type. In the case of productive type, that unique inclusion as a granuloma will be formed. If you remember some histology or pathonatomy, any granuloma consists of three main zones. It is central area where TB bacteria itself is present. It will be surrounded by macrophages which will emerge and form that multinucleated giant cells. It is attempt to inactivate bacteria to trap it here. Middle zone, which is made of epithelial or epithelioid cells, which are arranged radially, and it will form like a capsule around macrophages. And peripheral zone, which will consist of fibroblasts, which will make that dense tissue around first two zones. Lymphocytes are there to protect mycobacterium from migration. And of course, if it is some blood vessel, monocytes will be here around as well. So the main problem that macrophages cannot engulf, they cannot digest mycobacterium. And of course, they will understand that it is some dangerous microorganism which should be treated here. And if macrophage cannot eat it, our immunity will try to trap bacteria locally and make it not viable. So it is an attempt to isolate mycobacterium from air and from food, from liquids, to make it not suitable and to kill it not by digestion, by removal of oxygen and nutrients. So a few pictures here to show you the type of inflammation formation of granuloma, which is known as a tubercle, and actually tuberculosis is named because of formation of those unique tubercles. And where the capsule around first, central, and second peripheral zone will be formed, central area will go alteration and kind of cessation formation of that unique, cheesy, dense inclusion, it will be named as a tubercle. Those tubercles are easily seen on X-ray images, and of course, it's easier to identify in histological examinations or autopsy. That tubercle formed in a live subject can undergoes two uh, kind of outcomes. First one, it can break, and if it will breaks, it can break into bronchi, or it can breaks into some blood vessel. So mainly, content of that tubercle will be released, and of course, if that container will be released into the bronchi, those mycobacterium can be inhaled into other parts of the lungs, and a lot of smaller tubercles will be formed in lungs. And an X-ray, they looking like a millet, some millet grains, which were accidentally thrown on X-ray. And that type of disease, when a lot of small tubercles are identified in lungs, is known as a miliary TB. If those bacteria released by breaking of tubercles will be coughed out or will go into some bioreflexes in oral cavity, it can be swallowed, and in that case, extrapulmonary TB, mainly TB of gastrointestinal tract, can be observed. Second possible option, if that tubercle will be broken in the blood vessel, and in that case, mycobacterium can be delivered to any organ, and mainly it is some multiple organs, including bones in the human body. And in that case, the TB is identified as a disseminate TB, meaning that a lot of focuses will be absorbed over the body. So if we'll talk about common description of the disease, of course, source of infection is always human. We have kind of a carrier or inactive state, and we have ill human, which can be producing mycobacterium. We call it open TB cases, or carrier inactive state. Again, risk factors is mainly any condition leading to decreased immunity. Of course, if some HIV infection, cancer diseases, immunosuppressive therapy. In regular conditions, it was confirmed that actually malnutrition and medical profession is independent risk factor for TB. Use of some IV drugs and smoking again can increase risk, can increase rate of incidence. Disease can be transmitted by air droplets. Again, rarely it can be delivered by elementary way, but usually it is some engulfment of mucous secretion of lungs during coughing, and accidental cases of transplacental TB were described. Incubation period can be very long. It can last up to a year, and very often that disease is identified accidentally during routine examination of lungs by X-ray or because of some other reasons. Those focuses of calcification can be identified. Disease occurs in several stages. First one is prodrome stage. It is manifested by unspecific symptoms such as a weakness, some pale skin, subfebrile temperature, but usually they last for very long time. And of course, it's not a common thing when some temperature about 37 degrees remains for weeks, for months, and usually the condition is combined with loss of appetite. People can have night sweating. Slowly they will lose the weight, and if you see that some subjects have common symptoms of infection but very weak and last for multiple days, weeks, and months, it is the reason to suspect that some problems with the lungs as TB can be observed in those people. When disease will progress to main stage, cough will appear, and usually that cough is not very intense. It is dry, not deep, but it is constant. People always making some. It's not really a cough, but it is some attempt to cough, and usually they doing that sounds during talking, during eating, in common state, and with the time. You can see appearance of sputum very often with the blood because of destruction of tissues, and we call it hemoptysis. Pain in chest will appear because, again, some tissues will be destroyed. Of course, it will be painful. And later, you can see symptoms of respiratory failure, chronic respiratory failure, dyspnea, acrocyanosis, and low oxygenation of blood. If you will have some GIT complications in those people, they can have diarrhea, constipation, and appearance of blood and stool again because of destruction of epithelium of intestine and bleeding. Usually, disease itself is not acting as the reason of the death. In very prolonged cases, that prolonged infection of lungs can lead to massive necrosis and destruction of lungs, internal bleeding, lung bleeding, or acute respiratory failure. But mainly TB is co-infected with other bacterial infections. Some severe pneumonia will add, or disorders of GIT, such as a liver disorder, or even lung cancer can combine, and people dying because of concomitant infections of lungs. So few pictures of TB in upper part of the slide. It is respiratory TB. You can see that miliary TB when a lot of granules of white color inclusions of calcification are observed. In X-ray, again, it is keyed, but very severe state. The whole lung in both sides is affected with multiple millions of TB focuses. And as I said, frequently extrapulmonary TB is manifested by bone TB, and you can see that zones of decalcification in bone, when a focus of granuloma is formed, of course it will replace the bone tissue. And very often those people will go to a doctor because of some spontaneous fractures. They jump from not very high something, and bone is broken. It was some slight damage, but bone is broken. And during examination on X-ray or during surgery, doctor will identify that lesion, focus of bone destruction, and actually TB can be easily identified by any microbiological examination. Kidney TB is one of the most dangerous and frequent extrapulmonary type of tuberculosis. Again, it's easy to identify in ultrasound examination. You see those black empty cavities of tissue destruction, and granuloma is formed in autopsy again, or in CT scan. You can see the dense calcified tissues. The whole kidney can be affected and blocked with calcium. Of course, it will lead to renal failure, and people can die because of acute disorder of urinary tract organs. So we can talk, and actually you will have a separate cycle of physiatry in senior courses, and you will describe clinical presentations in more detailed manner. So our task is to provide you more knowledge about diagnosis, prevention of the disease. So how to identify disease? Of course, symptoms again are not very specific. Some fever and coughing can be a normal thing for some subjects living in cold areas such as Russia. It is always cold and discomfort. So a lot of people are coughing because they have some other problems. For identification of TB, we have skin allergic test as the main diagnostic tool. It is known as a tuberculin test or Mantoux test, and you will have two immunobiological preparations by that bacteria. It is a Koch tuberculin and PPD or purified protein derivative. So the first one was a Koch tuberculin. Koch designed vaccines, and actually it was an attempt to design a vaccine against Mycobacterium tuberculosis. Koch trying to dissolve Mycobacterium to obtain extraction of antigens and make a vaccine. But with Mycobacterium, that idea not worked. And when Koch tried to inject that dissolved by glycerin containing solvent debris of Mycobacterium tuberculosis, only redness and severe allergic reactions were observed in some people, and some people no reactions were identified at all. And Koch almost forgot that idea, but later he noticed that actually some people have reaction, but moderate, some have but severe, some have no reaction at all. And during further investigation, he identified that actually those people who were ill with tuberculosis had a huge reaction, very severe edema and severe allergic response. Those people who were not ill, never, and not ill now, they have no reaction at all. Those people who had some TB in history, but they're healthy now, had some kind of decreased reaction. And in further examinations and further studies, he identified that actually allergic reaction on injection of tuberculin corresponding with immunity against Mycobacterium. And he provided the test as a diagnostic tool. But the main problem with Koch tuberculin, it is very allergic even for healthy adult by itself. It contains a lot of non-specific components of Mycobacterium cell wall and give allergic reactions, sometimes non-specifically. So nowadays it is replaced with PPD. It is the same, almost the same extraction of cell wall components, but obtained by steaming and specific purifying technique. That test is more precise, less allergic, and more specific. So tuberculin test is provided according to international technique. Activity of that tuberculin should be measured in tuberculin units, and it is possible to measure only for PPD. Koch tuberculin cannot be measured because it contains a lot of non-specific components. So test is based on delayed type of hypersensitivity, and evaluation of the test should be performed about in 2 to 3 days. Actually, it's better to perform on third day after performing the reaction. So as we said, it is a skin allergic test, and one of the difficult things, it is intradermal injection. It is very specific technique. Not every medical nurse or doctor can perform it, and actually medical nurse who will perform the test should have specific certificate to perform the test. It is a specific needle similar to insulin needle. Intradermal injection of PPT is done in the forearm, and in 2 to 3 days reaction should be evaluated. We can have 3 main types of reactions. In 3 days we need to measure diameter of zone of redness, edema, or painful any reaction of hypersensitivity should be measured. And if that zone, usually redness is measured, is less than 5 millimeters, it means that reaction is negative. Subject have no immunity, no disease, but vaccination is not working, or subject maybe was not vaccinated at all. So those people are healthy, but they should be revaccinated or vaccinated if no vaccine was provided before. If reaction is between 5 and 10 millimeters, it is possible infection. Why possible? Because actually, if subject was vaccinated recently or previously, that reaction can be due to vaccine strain. And actually, every vaccinated subject should have that positive reaction between 5 and 10 millimeters. It means that subject, mainly in main number of people, it means that subject is immune but not ill. And if reaction of hypersensitivity is higher than 15 millimeters or any zone, but you can see alteration, severe inflammation with formation of some bullous or other vesicles, or especially necrosis of tissues, it is highly possible reactions. Means that people mainly will be ill with Mycobacterium tuberculosis. The main idea of the test is should be done regularly, and skin tests are preferred in kids. So every year, result of the Mantoux test should be recorded in medical chart of the kid. And doctor, usually it is a kindergarten doctor, then it is a school doctor, should compare result of current year with the result of previous year. And result should be approximately the same. It should not be changed significantly. If doctor seeing that result is decreasing, some 3 years ago it was 11 millimeters, 2 years ago it was 9, previous year it was 7, now it is 6, it means that immunity is decreasing. Usually it is observed when kid was vaccinated, but with the years immunity is lost. And it means that when reaction will become less than 5 millimeters, that kid should be revaccinated. But if the doctor sees that reaction is rising, it was 5 mils some years ago, then it became 7, 9, and now it is 11 or even 10. Still, if it is 10, it is looking like a normal reaction, but it is rising. It means that bacteria became activated and it is not a vaccine strain. Usually it is due to infection with Mycobacterium. So those people, those kids should be supervised by a specific pediatric doctor. Additional tests should be performed to confirm or to reject the diagnosis. Still, Mantoux test is not very precise because reaction is kind of approximate. So in main number of countries, per-care tests are used as the main type of diagnosis. In Russia, it is additional test for those kids who have positive Mantoux test. It is similar in principle, it is as well skin allergic test, but in that test you need to apply tuberculin solution in different concentrations, 1, 5, 25, and 100. And test is done with the help of lancet, specific lancet. You need to perform scarification of skin about 5 millimeters in depth and apply solution of tuberculin on those damages. And the same way, reaction is identified or measured in 2 to 3 days. But in that case, in the case of per-care test, we can have more number of different results. We have 3 main types of normal results. If you see that no redness, no allergic reactions is observed on neither concentration, it is allergic reactions, means that subject is not immune, not ill, and should be revaccinated if required. Non-specific reaction, when mild hyperemia is observed only in the maximum concentration of tuberculin, usually it is reaction on some components of the tuberculin. It is non-specific for Mycobacterium. Means again that subjects mainly are not immune. And we have hyperallergic reaction when you can see reaction on any dilution, but zone of redness, zone of hyperemia is equal to concentration of tuberculin. Means that 100% solution will give you the higher zone of allergy, less concentration, less zone of allergy. Usually it is again observed in healthy people who was vaccinated before. And we have abnormal results. Mainly they are identified in subject who is ill with TB. It is equivalent reaction when any concentration of tuberculin will give you equal zone of inflammation. Means 100% solution will have the same diameter as 1% solution. And we have paradoxical reaction when highest solutions, highest concentration will provide you the smaller zone of hyperemia. 2 reactions require more detailed medical investigation, medical help, because usually they are observed in people who have active TB. But anyway, any type of skin reaction is dependent on presence of vaccine strain of Mycobacterium. Because they are based on some common components of the cell wall which are observed on any Mycobacterium, including vaccine strain. So nowadays we have more precise technique. It is less popular in multiple countries. In Russia, it is only became known. In USA, the test is a standard test already, standard test of medical care, and it is approved in European countries in main number. And actually, common name of the test is IGRA test because of interferon gamma release assay name. So we have two test systems which are approved in international level in USA, in Europe, and in a number of other countries. It is called TB test and quantiferon TB Gold Plus test. Both have similar principle. One only blood test is required, and actually results of the test can be obtained within first 24 hours. And actually subjects should come only once. In hospital, you don't need to call it in 2 to 3 days to measure the zone. And of course, it is more specific because scarification test depends on external factors. If you will scratch the test, if you will apply some chemicals, maybe some cream or perfume, test can become false positive. It is very sensitive to even water, and if kid will wash their hand, test can become false positive. And again, vaccine strain can correlate with those tests. So IGRA tests are not dependent on BCG vaccination because they are based on specific antigenic structures of Mycobacterium tuberculosis complex, except BCG strain. And test is based on activation of T cells and release of interferons by stimulation with specific antigens of Mycobacterium tuberculosis. So test is much more precise according to different data. Specificity of the test is higher than 98%. It is very good test, and it is preferred for adults. For kids, still skin tests are preferred, and usually quantiferon or sport TB can be done as additional tests in kids. In those tests, two main types of results are possible: positive and negative. Positive is observed in people who are infected with mycobacterium. Negative result, it is described by manufacturers as disease is unlikely because still we have some descriptions of tests, of negative tests in ill people because of some problems with immunity. But tests became more and more popular. They're more specific, more precise, and requires less visits in hospital for subjects. It means doctors need to contact with those people less number as well. Treatment of TB is very complicated, very difficult, and very prolonged. The main idea that several specific drugs, and we have a unique group of antibiotics known as anti-TB antibiotics, and actually in Russia the average duration of antimicrobial treatment is 6 months. In India, you have some short regimens where month to 3 months course therapy is used. But in Russia, again, we have specific hospitals, TB hospitals. They're usually outside the cities to prevent contact with those people. And people are treated here for months, and they live in those hospitals for months. Multiple antibiotics, usually they're quite toxic, and a lot of adverse reactions are observed. The classic drug against TB is isoniazid and rifampicin, and we have a lot of some ethambutol, streptomycin, kanamycin, and a lot of different drugs. But the idea that people usually need to take 2 to 3 drugs at the same time, and those drugs should be regularly checked to prevent antimicrobial resistance in mycobacterium. Of course, one of the most important factors is proper nutrition. You need to provide proper feeding, a lot of vitamins, diet rich with proteins, and if required, lung oxygenation therapy to improve oxygenation of organs and tissues. Again, in Russia, the main risk factor for TB is previous poisoning or some societies of very poor homeless people. And usually those people will not look for medical help in timely manner, and they will come to doctor in when some serious problems are observed, such as bleeding in lungs or some other. And very often those people require surgical management, some resection of lung or some tissue. And it can be very difficult because common state is severe, multiple antibiotics are required, and surgery is not a very good way for those people. Prevention of disease should be done again in two manners. First one is non-specific prophylaxis. Means that subjects who are identified to be active carriers or active producers of mycobacterium, of course, should be isolated immediately. And until those people have mycobacterium identified in sputum, they should not have a contact with community with other people. They should be provided with isolated ward if that hospital, TB hospital, is not available. But anyway, the main idea you need to isolate those people to prevent infection in the father. Of course, you need to check family members, close friends, and close contact people. If they was working in some close collective, everyone should be checked. Independent factor, risk factor is poor nutrition. So to prevent disease, especially for doctors, for medical professions, proper and full nutrition is very important to prevent the disease. And in some studies, publicized studies, it was shown that those medical workers who had good nutrition, they had normal weight or even overweight, they were less affected by TB than skinny and malnutrient people. In multiple countries, we have obligate regular state examination in adults. Especially, it is important for doctors to identify TB in lungs in timely manner if it is present, to identify those calcified focuses. And we have unique type of X-ray examination, which is known as a fluorography. It is very high dose of radiation given for short time period, and mainly the whole lungs will be seen as a black, and if any calcification is identified, it will be seen as a bright white millet, as I showed you in some previous slides on the X-ray. And of course, in kids, regular performing of skin test, TB, tuberculin test, or PEPK test to identify immunity to prevent infection of kids. Of course, the main measure is specific prophylaxis, and that BCG vaccine is one of the most known. We have actually two, DTP vaccine and BCG vaccine, which is always very good answered by students and known even in a medical society. Name is given because of two scientists who grew the bacteria and obtained vaccine strain of Mycobacterium bovis, Calmette and Giren, and Bacillus Calmette Giren is the name of the vaccine. It is weakened Mycobacterium bovis, which is nowadays belong to Mycobacterium tuberculosis complex. And worldwide regimen of vaccination is 2 doses. First one in the first days of life. Usually it is done in hospital while kid is not discharged, in up to 3 days, maximum 5 days if some contraindications are present. And revaccination in Russia is up to 7 years, in India is up to 5 years, and revaccination should be done according to Mantoux test. While it is stable, it's not decreasing, not rising, revaccination is not required. When that zone of hypersensitivity will start to decrease, revaccination should be done the same year. But again, in Russia, we observe kids up to 7 years. In India, it's only up to 5 years, and vaccine should be done in maximum possible period. One of the questions which is very popular now, and if you will try to search in any system, I use Google, one of the most popular questions nowadays: can BCG vaccine prevent you against COVID infection? And it is because in the very beginning of that epidemic, few publications became available that people who was vaccinated with BCG has lower incidence and more mild duration of the disease. But after that, that topic was kind of forgotten and a lot of other things were discussed. But nowadays, again, the question is came back. And if you will search a lot of different questions, will appear a lot of articles. And in common way, we should say yes, it is confirmed and it was shown in multiple countries by multiple doctors and scientists that people who were vaccinated with BCG, they have uh, milder duration of the disease, they have lower incidence of the disease, and the main thing that BCG vaccine will activate cell-mediated immunity, and always vaccine strain of Mycobacterium bovis is surrounded by multiple immune cells, macrophages, giant cells, lymphocytes, fibroblasts, and a lot of. And our cell-mediated immunity is always kind of activated because of that BCG strain. And it was shown that actually COVID infection activates and depends on cell-mediated immunity as well. And it is confirmed that people who were vaccinated with BCG vaccine have just higher activated cell-mediated immunity. And when they became infected with COVID infection, less time is required for immunity to react on that viral infection. And previous vaccination, scheduled vaccination with BCG, kind of protecting people against COVID infection as well. So again, similar problem with tuberculosis as in with other diseases, preventable diseases. Previous decades, we had in our country, we had decrease of BCG because of very high rate of vaccination in community. And nowadays, control over vaccination is decreased, and actually we have again a lot of people who are not willing to vaccinate. They have a rule to, they have an option to refuse of vaccination. And in general, less number of people have immunity, and rate of tuberculosis is rising as well. And it is the reason, maybe it is the reason why COVID infection is so prevalent nowadays as well. Previous decades, all countries had obligate vaccination against BCG, and nowadays it is optional. And actually, that COVID we will discuss later in some viral topic, that COVID virus. But it is virus which was described in some 1970s years, and it was known for decades as well. But it was not so popular, it had no so high prevalence in people community, in human community, maybe partially because of BCG vaccination. And nowadays, officially, multiple countries reporting decrease of BCG vaccination, and you can see that COVID infection became extremely dangerous and acute as a pandemic.